Good morning, everyone, and welcome to our Blackrock Clinic study morning for GPs. Thank you all for coming out on a wet Saturday in January. Not always easy to get out of the bed, but I suppose you wouldn't really be doing much else this morning, so thank you for coming. This morning's session is entitled All Things Alimentary, and we've got 3 sessions this morning rather than the original 4 that were flagged. So we're not doing the radiology one this morning, we're doing the 3 gastrointestinal ones. Also, just to say, Blackrock Clinic are planning on rolling out live webinars, and we're doing a test pilot webinar this morning. So we are going to record this morning's sessions, and they won't be transmitted live this morning, but we're going to record them to see how they get on for the live webinar format later. So as I say, this morning's session is entitled All Things Alimentary, and our first speaker this morning is Mr. William Robe. William is a consultant upper GI and bariatric surgeon, and his talk this morning is entitled Dyspepsia, Dysphagia and Obesity. Thank you, William.
Thanks very much, Barry, for your introduction, and great to see you all here today. So, Barry, as Barry said, my name is William Robb. I'm an upper GI surgeon. I work over in Beaumont Hospital on the dark north side. So, many of you may not have had as much contact with me as others. So my background, after training in Ireland, I spent a couple of years in Lille in northeastern France in a really high volume upper GI cancer centre, probably Europe's biggest cancer centre for esophageal and gastric disease, and then spent a couple of very happy years in Bristol before returning back to Beaumont, to the upper GI service there. And I thought today I'd really go through with you all just a few of the upper GI symptoms which you probably see commonly in primary practice, and also then talk to you a little bit about a couple of my interests, the area of Barrett's esophagus, endoscopy for that, what's changing there, esophageal cancer, what's changing there, and also talk to you about a little bit about obesity surgery, because really obesity in our population ties into all of these upper GI complaints. It ties into patients having increased reflux, increased dyspepsia, and increased problems with esophageal cancer, and the whole remit of upper GI symptoms often tie into weight as well. So you all know what dyspepsia is. It's this kind of syndrome of epigastric pain, burning feeling in the upper abdomen, postprandial fullness, maybe a sense of early satiety after eating that patients can complain of. And it's not an uncommon presentation to either us in hospital medicine or to you in general practice. About 40% of adults will experience some form of dyspepsia at some stage. And a lot of us have had some of those symptoms at some stage. And it's thought, I don't know if that figure you feel is a little bit high, but it's thought about, it probably comprises about 4% of your consultations in primary care. And as you know, there are 5 real causes for patients presenting with dyspepsia: gastroesophageal reflux disease, patients on medications, whether those are non-steroidals, aspirins, or a multitude of other medications can cause some of these symptoms. Patients can have functional dyspepsia, where there's no organic or mechanical cause for their dyspepsia being found after they're investigated. They can have a bit of gastric hypersensitivity after they eat, under distension of their stomach, slow gastric emptying. All of those factors can go towards causing patients having some of these symptoms when they don't have an organic cause. But underlying all of that as well, you have to bear in the back of your mind when patients present, especially with a new onset dyspepsia in the older population or the population over 45 or 50 years of age, you have to have alarm bells ringing a little bit that could be a presentation for malignancy of the upper gastrointestinal tract as well. So the pathogenesis, really there are three factors: infection with H. pylori, which can obviously be treated, increased gastric acid secretion, again, which can be treated simply with antacid tablets, and in some patients there may be some altered gastric motility which gives rise to some of these symptoms, and sometimes a prokinetic or a trial of a prokinetic can be of some help. So what would I suggest is, and a lot of this I'm sure you're very familiar with, what's the practical management of dyspepsia in primary care? I'd say dyspepsia without alarm symptoms, and those are the patients who are maybe young and present with some of these symptoms of upper abdominal pain, a bit of reflux, heartburn, discomfort. The basic advice is lifestyle advice, and you all know that. Alcohol, cut down on alcohol, which can contribute, stop or cut down smoking. Caffeine, reduce the caffeine intake, reduce spicy foods, which can aggravate these kind of things. And also reduce body weight, because certainly if you're overweight, you tend to get more reflux and heartburn and dyspeptic type symptoms. I think it's very reasonable to empirically try treatment for a period of 6 or 8 weeks with a PPI, especially in young patients without alarm symptoms. And very often that will treat and calm down a lot of patients' symptoms. What does test and treat mean for H. pylori? Well, it means testing a patient to see if they're H. pylori positive. That can be done either with a breath test if it's available in your practice. If not, patients can be referred for a breath test, or indeed serology. And if patients are H. pylori positive, it's very reasonable to go ahead and eradicate their H. pylori and give them a 6-week course of an antiacid tablet and see if their symptoms resolved. And I suppose that's really recommended for patients who are young, in the younger age group. Less than 50 is the broad guideline from the NICE guidelines in the UK, and who do not have alarm symptoms. But if a PPI trial fails, or if after they have their H. pylori eradicated and they're still symptomatic, then even those young patients should be referred for endoscopy. H. pylori can be diagnosed, as we've mentioned, with a breath test, which is really pretty sensitive and pretty specific. It's a good test, stool antigen test if available, and patients need to be off their PPI for a couple of weeks, and I think they also need to be fasting for the breath test. It's not something we routinely do in hospital. I suppose most of our patients are tested for H. pylori with a biopsy taken at the time of endoscopy, and then we can do a Clo test or indeed see the organism on the histology. So I suppose when we eradicate H. pylori, the treatment benefit tends to benefit patients with gastritis and inflammation of their stomach, but it won't cure necessarily patients who have gastroesophageal reflux. So the reflux symptoms may persist. I think it's worthwhile just noting that the recommendations for treatment and eradication of H. pylori have changed a little bit. It used to be, and certainly when I was in medical school, we were taught a 1-week course of antibiotics and 6 weeks of a proton pump inhibitor. But there's quite good evidence that if you prolong that treatment with antibiotics a little bit longer, and this is a Cochrane review, meta-analysis of 55 studies, and it came out in favour of 14 days being the optimal length of treatment with antibiotics, and increasing the H. pylori eradication rate up to about 82%. I tend to kick for touch a little bit and probably prescribe antibiotics for about 10 or 12 days. I think 14 days compliance may be an issue with patients taking it, but I think probably we should prescribe it for longer than a week to try and maximize the eradication of H. pylori. You have to remember that H. pylori, when it's found, should be treated because it is a risk factor for malignancy of the upper gastrointestinal tract. So when we find peptic ulcer disease on endoscopy, and your patients who come in to us and we find out a gastritis or an ulcer on endoscopy, how should we treat it? Well, we stop the aggravating factors, so stop non-steroidal anti-inflammatories, start on a full dose of a proton pump inhibitor, eradicate H. pylori, and of course if a patient has a gastric ulcer, they need to have a follow-up endoscopy to make sure that that gastric ulcer has healed, because certainly gastric ulcers can be malignant. So a repeat endoscopy to make sure that there's ulcer healing would be very important. So there's some literature coming out, and it's concerning literature really about patients who are on long-term proton pump inhibitors. And I think it just raises our threshold a little bit with patients in giving them long-term PPI treatment. Because here's a very large population-based study coming from Sweden, and in Scandinavia they have fantastic databases for their population to really interrogate and look into. This is a study of 750,000 or almost 800,000 patients who are on maintenance PPI therapy, and it looked at the risk of developing gastric cancer. And it's been published fairly recently, just last year, and it said that long-term PPI use was an independent risk factor for developing gastric cancer in the population. So what does that mean? It doesn't mean that we stop prescribing proton pump inhibitors in the long term, but I think it certainly makes us think about, does this patient need to have a proton pump inhibitor, or are they on it unnecessarily, and deciding if patients are just be on it because they've always been on it, then perhaps they can be taken off it and be given a trial without their proton pump inhibitor. And I think that's just a practical approach to that. So the NICE guidelines are very clear about who needs to be referred urgently for endoscopy. And they have a two-week wait rule in the UK. I don't think we have the exact equivalent here in Ireland. And they really say that direct referral for endoscopy, if a patient has dysphagia, irrespective of their age, they should have an endoscopy. And I think that's very sensible and clear advice. When patients present with dysphagia, we must outrule a mechanical cause. Cancer obviously affects the older population, but within the last year I've had 2 young females, one who was 21 years of age, one who was 26 years of age, both presented with new onset reflux dyspepsia, treated with a PPI, didn't resolve, and thankfully both referred for endoscopy, both had advanced esophageal cancers, and both have been through treatment, both have had esophagectomies. So I think that's a real warning that we're seeing this disease earlier and earlier. So in patients of any age who have dyspepsia or gastroesophageal symptoms which are not responsive to treatment, or they're unexplained symptoms, I think you have to think about sending those patients for endoscopy as well. And obviously the older age group with any of the alarm symptoms, upper abdominal pain, reflux, dyspepsia, any of these kind of alarm symptoms need to be referred directly for endoscopy. And also, in the younger age group with new onset dyspepsia, I think it's very reasonable to give them a trial of treatment and see if it resolves. But as we creep into our 40s or 50s, new onset dyspepsia has to send an alarm bell, and I think those patients should be referred for endoscopy. So dysphagia is obviously a sinister symptom, dysphagia and weight loss even more so. And when any of us see a patient who's got dysphagia and weight loss, we have to think esophageal cancer before anything else, and those patients need urgent endoscopy. The Esophageal Cancer Fund Lollipop Day is coming up. Again, I'm sure most of you are familiar with the Esophageal Cancer Fund. Noelle Ryan has done a fantastic job in setting that up and driving it forward. She runs a fantastic patient support group now for patients with esophageal cancer, and we meet with patients who have survived or are going through treatment once every about 3 months. And have a really good session just like this with them and answer questions with them. And it's been a fantastic drive, I think, in Ireland to heighten awareness of upper GI symptoms. It's the symptom of dysphagia. The lollipop is being used as the symbol for sucking and swallowing to try and highlight that dysphagia is a sinister sign and should be investigated. I'm going to talk a little bit about obesity in a few minutes, but obesity, as I said at the start, is linked into it's a risk factor for reflux. Reflux can lead to Barrett's, and certainly obesity is a risk factor for a whole series of cancers, and that's no different with upper GI cancers. If patients are morbidly obese and have a BMI of over 35, their risk of developing either a gastric or esophageal cancer is almost twofold that of the normal population. So I'm going to change track a little bit now and talk to you about what's new for your patients with Barrett's esophagus, what should be the standard of endoscopy that they have, and what's changed there. Because endoscopy for Barrett's is becoming more and more of a niche and specialist area, and I would be in favour that all patients with Barrett's are having their endoscopy performed by somebody who's I suppose aware of the changes in how we're assessing Barrett's, and is that the endoscopy is done by a specialist in that area. So there are new techniques on endoscopy. I'll show you a couple of pictures where we can look at the esophagus under narrowband imaging, different light, and we can also spray the Barrett's mucosa with acetic acid and look for evidence of dysplasia, which isn't obvious under normal light. We can use radiofrequency ablation as a local treatment for dysplastic Barrett's, and we can essentially use a balloon catheter to fry and ablate the esophageal lining in patients who have dysplasia, and then the esophageal mucosa regenerates normally as squamous epithelium, and we get rid of Barrett's in that manner before it progresses to cancer. And also for very early esophageal cancers, perhaps a small nodule of early cancer with a background of Barrett's, what's called T1A tumours, so cancers which are confined to the mucosa. we can treat those endoscopically and remove them and avoid an esophagectomy. And only 10 years ago, patients with high-grade dysplasia in Barrett's or patients with T1A cancers were getting an esophagectomy, whereas now that can all be treated endoscopically. So that's quite a big change. So as I said, it used to be that if you had high-grade dysplasia in Barrett's mucosa, or you had a very early T1 tumour, you bought yourself an esophagectomy, which is an operation with significant risk and morbidity. But that's no longer the case, and we've good evidence to say that if you have high-grade dysplasia or low-grade dysplasia on two occasions, you can have endoscopic treatment. Here are just a few examples of what I mean by the different techniques we can use for Barrett's. This is a normal endoscopy, and you can see this is normal squamous mucosal colouring of the esophagus, and then this is the metaplastic Barrett's esophagus here. And when we spray acetic acid into the esophagus, just using a spray catheter in endoscopy, the metaplastic epithelium will blanch and turn whitish. But areas of dysplasia don't blanch, and they remain pink and red, and therefore we can target our biopsies much more carefully to try and identify, rather than just taking random biopsies which can miss dysplasia, we can try and target our biopsies much more carefully and find out if a patient has developed dysplasia in their Barrett's esophagus. So that's one imaging technique we can use during endoscopy to try and improve, if you like, the hit rate of defining who's got dysplasia and who doesn't. And then we can use different light to look at the lining of the esophagus and narrowband imaging to highlight vascular abnormalities or areas which may be suspicious for dysplasia. And then when we find an esophagus like this, you can see down here there's a bit of nodularity in this esophagus here. We can do something called an endoscopic mucosal resection, which I'm sure you've probably heard of, where we simply put a cap on the end of the endoscope. We suck up the small nodule into that cap on the end of the endoscope, and then we can resect it. And we can resect the mucosal lining of the esophagus and take away an early nodule like this, send it away to the laboratory, have it analysed. And if that is a very early mucosal cancer and the margins are clear, then that's all the treatment that the patient needs. They do not need an esophagectomy. Because with very early mucosal cancer, we know the risk of having lymph node metastases is about 2%. And I suppose traditionally the risk of mortality having an esophagectomy was somewhere in the region of about 2%. So there's a balance of risk there. So I would suggest to you that this is becoming a specialist area. This is just a picture of the balloon catheter which we can put down the esophagus to ablate dysplasia with. And certainly we can do endoscopic mucosal resections for these kind of nodules in the esophagus. And now in Beaumont we've got a fortnightly specific list where we have Barrett's patients on our lists. It's dedicated to Barrett's patients. We perform all those kind of techniques for them. And it's very focused on just dealing with Barrett's. And I think patients with Barrett's, they should all be having that kind of service. Just a quick mention of what's new in cancer of the esophagus, or surgical treatment of cancer of the esophagus. And in Beaumont we do a lot of these cancers now completely minimally invasively, which is a big step forward. So we do a laparoscopic abdominal operation and we do a thoracoscopic esophageal operation. And that's, it's a highly technical kind of operation, but in terms of recovery, there's less blood loss during the operation, there are fewer respiratory complications, the patients don't have that big mutilating thoracotomy, we can avoid that. They've reduced post-operative pain, reduced post-operative pain, they stay in hospital for shorter lengths of time. And really, I'm going to show you a little video of how we do it. We'll skip through it fairly quickly, but it'll break up the monotony of the presentation, and you might be interested in seeing it. And I think the advantages of minimally invasive surgery, even for patients with esophageal cancer, we know that we can do the same oncological resection. So we can resect the tumour as radically. We can probably take out slightly more lymph nodes, actually, because the vision's so good. So I think it's actually a better oncological operation than an open operation, and certainly patients recover from it more readily. So I don't know if we can just play the first 20 seconds and then we'll skip on to about 3 minutes. Would that be okay? Yeah, just press play. So this is just in the abdomen. And in an esophagectomy, we have to make the stomach into a long, narrow tube to replace the esophagus with. This is the liver hung up here, and then the esophagus is coming down through the diaphragm here. So that's just a stapling device that we use. We tend to put in a feeding jejunostomy in all of our patients, and I think we'll do that. And then we can do a really quite radical transhiatal dissection. This is lung. This is the muscle of the diaphragm here on each side, the V shape of the crura. This is the aorta, and you can see we can get all the lymphatic tissue stripped off the aorta, and this is all done through the abdomen, this part of the operation. And we can do a very nice dissection and broad dissection. We could skip on there to about 3 minutes on the video, just it's about halfway across, left a bit, I think, left, somewhere about, what's that? Yeah, perfect. Then this is up in the chest. This is the esophagus draped up here, and you'll see now just in a minute that we're able to reach down and then pull the stomach that we've made into a tube up through the diaphragm, which is on the left, and this is all done through keyhole surgery, and we can pull it all up into the chest and then check that it reaches right up into the apex of the thorax. These are the ribs, obviously. We're just dividing the esophagus here. So this is now the stump of the esophagus. And this is the biggest incision the patient has during a minimally invasive surgery. It's about 4 or 5 centimeters in size. We put a little retractor in between the ribs, and we can pop the specimen out through that very small incision and take it out. And then the last part of the video just shows, here's the aorta laid bare. This is the back of the heart with the inferior pulmonary vein. And then as we move up, all the lymph nodes have been taken out of the subcarinal space. This is the main bronchus going into the right lung. And we've done a fairly good and radical lymphadenectomy, and that's the stump of the esophagus. And then just the last bit to show you is we use a very clever device which is passed down through the mouth, and then we pull it out through the stump of the esophagus, and it's got a circular anvil on it. And then through that very small thoracotomy, we can pass a circular stapler into the stomach, pass a spike out through the wall of the stomach, and then dock the spike into the anvil that's up in the esophagus, join the two together, and close the stapler. And that forms the circular stapled anastomosis to join the stump of the esophagus onto the stomach. And only about another 10 seconds of this, and then we can just staple off that little pouch of stomach and then secure it in place. So, you know, in Beaumont and Cork's the only other centre, I think, in Ireland currently performing esophagectomy by completely minimally invasive technique, but I think it's going to be the way forward in the future. And I would anticipate in Beaumont as well, as robotic technology gets going, that we would also hopefully have access to a robot and be able to perform robotic esophagectomies. And certainly the flexibility of the robot in the chest and the thoracic part of the operation will be fantastic. Now, as I mentioned earlier, you know, cancer is a risk factor, or obesity is a risk factor for cancer. And over there on the side, as I mentioned, you know, when you look at esophageal cancer and look at stomach cancer, the relative risk of developing those cancers in patients with a BMI of over 35 is twofold. So that's significant. And we know there's really good data to say that as soon as your BMI goes over 35, your mortality risk and your life expectancy decreases exponentially. And that data is very strong. And that's the reason, and it's the reason that we should consider patients for weight loss or bariatric surgery. It's not a cosmetic operation, it's actually an operation to improve long-term health. How do we fare in Ireland when we talk about weight loss surgery? Well, we fare very badly. And it's highlighted in the press repeatedly that we don't really have a functioning public bariatric service nationally, and we need to do much more of this operations. I heard Donald O'Shea being interviewed recently about the new paediatric hospital or children's hospital, and the fact that there was going to be some bariatric surgery there for our adolescents. But we're not even providing that service for our adults at the minute. This is a little bit outdated, but when you look at a country of similar size to Ireland, Denmark's got a population of 5.4 million, not dissimilar to us. They do 2,000 operations for weight loss every year. Sweden's got a population of probably twice our population. They're doing 10,000 operations for weight loss every year. So I'd say in Ireland, with our population, we should be doing about 2,000 operations a year, and that would suit our population, and our population is actually one of the most overweight in Europe. And yet we're probably doing about 100. So that needs to change. It needs to change radically in both public practice and in private practice. It needs to change across the board. It's costing us a lot of money, the fact that we're not providing this service. It's costing the health service a lot of money in long-term health costs and looking after these patients and their comorbidities as time progresses. And if we don't provide the service, well, medical tourism is, people are forced to look abroad, and patients will take the option and they'll decide to go to Belgium or wherever else and have a gastric band put in. And often if you get a Ryanair flight, you get a Ryanair either operation or Ryanair follow-up service. And that would be a concern that, you know, patients who travel for their weight loss surgery don't have access to the team who've actually performed the operation. And I'd have some concerns about that. And certainly in our emergency departments, more and more frequently we're seeing patients turn up with problems with their gastric bands and other problems. And really, while some of the overseas services, I think, do have quite good follow-up services which come to Dublin, ideally I think it would be more sensible for patients to have an operation in their own country where they can be followed up closely. So who qualifies for weight loss surgery? Well, essentially, the international guidelines tell us that these are the patients we're interested in. Patients who have a BMI over 35 to 40, who have comorbidity associated with their weight, or patients with a BMI of over 40 qualify without comorbidity. Now, the Irish health insurers have raised the threshold a little bit, and to qualify under Irish insurance laws, you have to have a BMI of over 40 with comorbidity or over 45 without comorbidity. So the threshold to qualify under the insurers is slightly higher. In the last year, we've put a lot of work into this in Blackrock. We've got our own weight loss surgery at blackrockclinic.ie website up and running, and myself, along with Mylon Aramagasamy, are the two surgeons providing this service there. And patients and yourselves can look at this website. It gives good information about who qualifies for surgery. We've got a very good multidisciplinary team in Blackrock. We've got a very good endocrinologist, Dr. Jean O'Connell, involved. We have fantastic dietitians involved who follow up our patients. And we've got a good access to all the other ancillary services we need to run this service. And those are the two operations we do, really, primarily a gastric bypass or a gastric sleeve, which are restrictive and malabsorptive operations. Certainly the bypass, the gastric sleeve is more restrictive on what patients can eat. And we get fantastic outcomes from these. And when you see patients back after these operations and they're losing weight, they're more mobile, they're participating in family life, they're getting back to work, their psychological well-being is vastly improved. It's really rewarding to see. So either your patients or yourselves can access us through our site and find out our contact details and get in touch if you have patients who want to be seen and just be assessed about this. And on a word of warning, I wonder if we're going to go down this route and all. This gentleman in Australia got a payment of $350,000 in Australia because his physician had failed to refer him for bariatric surgery. And I think both his diabetes and liver disease progressed, and he felt that he should have been referred for at least assessment for weight loss surgery. You know, I wonder if that will be the environment in which we find ourselves as well. So listen, thank you very much for your attention. I'd be very pleased to answer any questions.
Move over there. Okay, both? Just William. Okay, William, I'm going to ask you to move over. Speak over there. All right, yeah. That's fine, okay. Now, just for the questions, you do need to have a microphone in order to answer the question. So we might start here.
Thank you very much, Bill, for a wonderful talk. Just a point to let the GPs know that long-term PPIs cause osteoporosis.
Yeah.
and it increases bone loss, and I don't think a lot of them realise that.
Yeah, it's a very good point. I think there are concerns. There have also been concerns about long-term PPI use and dementia and other things in the medical literature. So I think we just have to be cautious with their use. Very good point. Thank you.
Oh yeah, that was great. Thanks a million. I'm just wondering, in terms of adults that are overweight, who are morbidly obese and they lose a lot of weight, they tend to gain it back.
Yeah.
So, I mean, what do you do
Why?
with those? Yeah.
Yeah, there's more and more evidence to say that once an individual, once a human becomes morbidly obese, they reset what's called their set point of their weight. And I think it's felt there's very complex probably interplay between gut and brain and messaging between gut and brain. And once a patient becomes morbidly obese, their body resets their expectation that that's the weight they should be. So the vast majority of those patients, and there's extremely good evidence about this, that they may be able to lose weight, but sustaining weight loss is extremely difficult for them, and they will yo-yo up and down and will always return to their former weight or even beyond it. I mean, I come from a sporting background. I would have always, until about 5 or 6 years ago, 7 or 8 years ago, thought, well, eat less, exercise more, was the simplistic answer. But it's definitely not as simple as that.
Many patients who are taking PPI, but still their treatment is refractory, they are not responding. They are coming again and again and said it's not working.
Yeah.
What will be your next step then?
Yeah, I suppose if the patients have, if they have true reflux and the PPI is not effective, then those patients can be assessed for anti-reflux surgery. So if a patient has true heartburn, and if you had a patient who said, well, my PPI is no longer effective, I'm still getting heartburn, when I see those patients, I would send them for a few investigations. Number one, I would do an endoscopy to see if they have evidence of esophagitis and burning of their lower esophagus despite their PPI. And I would also send them probably for 24-hour pH studies where they have a little catheter placed through their nose for 24 hours. It sits in their esophagus, and they have a 24-hour period which measures how much acid heartburn is actually coming up. And they have a little monitor, so when they feel symptoms, they press a button, and that can we can see if it correlates with actual episodes of acid reflux. And if those patients have good documentary evidence of reflux being the cause of their symptoms, and if they're poorly controlled on a proton pump inhibitor, then those are the patients who ideally should be considered for anti-reflux surgery. So a Nissen fundoplication or other type of anti-reflux surgery. I suppose you have to be a little bit careful. Sometimes patients come and they're put on a PPI, or we treat them with a PPI, but their true problem isn't acid reflux. So you have to just make sure that their true problem is acid reflux, because a proton pump inhibitor will be very effective at treating acid reflux, but may not be effective at treating other upper abdominal discomfort.
Sorry, just to have a second question. How you manage bloating? A lot of people
Yeah.
have.
Difficult, because some of those patients with bloating can have bloating from other causes. They may have, they may have food sensitivities. They may need to try a different diet, a gluten-free diet. They may have gallstones causing bloating, or they may have just an irritable bowel type syndrome, or they can have what we call functional dyspepsia without an organic cause. Some patients who have no organic cause for their bloating and dyspepsia can be tried on a PPI to see if it makes a difference. They can be tried on a prokinetic to see if it makes a difference. But then if they're not settling on those, I think it's a good idea for them either to see a dietitian or indeed to see a gastroenterologist and consider a change in their diet.
William, can I ask you, just in relation to the patients with Barrett's, so I suppose we would generally have them on long-term PPIs, and so obviously that's to reduce their esophageal cancer risk, but then possibly they have an increased gastric cancer risk.
Yeah.
So is there a length of time, because it's not uncommon now to see people with Barrett's like in their 20s, so are these people going to be on PPIs for 40, 50 years?
Well, at the minute, yes, that's the treatment. I think it's to make sure that they're not on too high a dose of a PPI and they're just on a maintenance dose of a proton pump inhibitor, because some of those patients won't have bad symptoms of acid heartburn, but certainly at the minute, especially if they've long segment Barrett's, there's good evidence that they should continue on that. It's felt that that decreases their esophageal cancer risk, but now there seems to be some evidence that long-term PPI use may increase their gastric cancer risk. And we're certainly seeing more and more proximal gastric cancers, and you know, there's a question as to whether it's related.
Okay, well, listen, I think that's that for that session. Thank you, William.
Thank you very much.
Thank
Thank you.
That was
Yeah,
very
great.
good. Thank you.
Thanks very much. Oops.
Our next speaker is going to be Dr. Conor O'Brien. So I'll invite Conor up now. Conor O'Brien is a consultant gastroenterologist in Blackrock, and Conor is going to be speaking to us on colorectal cancer screening, when, how, and who to screen. Thank you, Conor.
Hi, how are you? Okay. Thank you very much for the introduction, and thanks for turning up today with the weather outside. My talk today, colon cancer screening. Okay, who, when, and how. And just to give you an outline, I'm going to talk about colon cancer in Ireland first. What are the screening options when a patient comes into you and says they want to be screened for colon cancer? And then I'm going to talk a bit about the guidelines. Then I'm going to talk about the Irish experience with the bowel screen fit test to date, quality in colonoscopy, and then risk factors for colon cancer if we have time at the end. So colon cancer in Ireland, 2,000 to 2,500 new cases per year. And deaths from colon cancer account for 11% of all cancer deaths. And it's the second most common newly diagnosed cancer in both men and women in Ireland, and the second most common cause of cancer death in Ireland per year. Lifetime risk for an individual is 5 to 6%, so it is a big problem. The age standardised incident rate is unchanged over the last 20 years in Ireland. Okay? The actual incidence, the numbers are increasing because the population is aging and the population is increasing. So the numbers are going up, but when you standardise it for age, it's not increasing, which is good. The mortality rate, thankfully with improved treatments, is coming down. And this has coincided with, this is the American experience, with the screening, is this a pointer there? No. The black line at the bottom is the screening, and that started in America. Let's point to there. Once they started screening in America, the incidence rate started to come down. Okay, it's not all due to screening, but a large part of it is due to screening, and that's of course the whole aim of the screening program, is to reduce the incidence and the mortality of colon cancer. So why do we screen for it? Obviously, we know it's an important health issue. It's great. There's a latent stage. There's polyps that take, in most cases, about 10 years to become a cancer. So there's a stage there we can act to prevent colon cancer. There's a defined at-risk population. There's good diagnostic tests available. There's a treatment, and it's very cost-effective. All the things you need for a good screening program. And you've all seen this cartoon of the polyps turning into a cancer over a number of years. Now, the reason I'm going to talk a little bit about polyps is some of the screening tests pick up some polyps and not others. And that's why we're going to do a brief run through of polyps. Conventional adenomas are either pedunculated or sessile. Okay, and these are conventional adenomas. You've all seen these pictures. 70% of colon cancers start off with these conventional adenomas. The problem is the other 30% start in this new class of polyp that's been described, the sessile serrated polyp. And as you can see from the pictures on your left, they are very, very subtle and very easy to miss. They primarily arise in the right colon, and this is a part of the reason the mortality from right colon cancer has not shown as big a decrease with screening as left-sided. And as you can imagine, the bowel prep is going to be pretty important to be able to see these small lesions. So how do we do the screening? What are the modalities available? So the non-invasive tests first, fecal screening tests. Predominantly detect colon cancer, not polyps. Everybody who has a positive one needs a colonoscopy. There's the fecal immunochemical test that's the most commonly used one. It's the one that's used in the National Bowel Screen Program. The fit fecal DNA test I'll talk about. The standard fecal occult blood test is no longer recommended for screening because it's not good enough. Okay, I'll talk about that as well. The immunochemical test, they're antibodies specific to human hemoglobin. Doesn't interact with dietary, meat or anything like that, so it's less prone to false positives, reasonably low cost. The sensitivity for detecting colon cancer is almost 80% with a specificity of 94%. The sensitivity for an advanced adenoma, which is a large one, or a high-grade dysplastic adenoma, is much lower. These fecal tests detect primarily colon cancer, and it's the test of choice in programmatic screening, like in Ireland. Pitfalls with them, they require repeat testing every 1 to 2 years, and they don't detect the serrated adenomas. Okay. The fit fecal DNA test is a combination of a fit test and a test that detects sloughed off DNA mutations in the stool. Has a high sensitivity rate, but it's much more expensive than the fit test, and that's why it's not used here in Ireland, and it's not used in programmatic screening until it becomes cheaper. The standard fecal occult blood test you're all aware of, a lot of false positives with it. It's now essentially been replaced by the fit test. Okay. To summarise, with fecal screening tests, they can detect early stage tumours with repeated testing. Mortality is reduced. Sensitivity for the precursor lesions, the polyps, is not great with the fecal screening tests. Many don't adhere to annual testing, and that's human nature. Okay, if it's a repeat test that needs to be done every year or two, a lot of patients don't adhere to it, and the follow-up is crucial if they've got a positive test. Okay. Another non-invasive test is the serum test, and you're going to, I put this slide up because all the patients will ask you, a lot of the patients will ask you, cannot do a blood test to screen for colon cancer. The answer is you can, but it's not very sensitive. There's the Septin9 assay, which is available, not really readily available in Ireland. Sensitivity for detection of colon cancer, 48%. It's not great. The fecal tests are much better. It's not recommended for screening. So just a case, a 38-year-old lady, mild symptoms, bloating and flatulence. She's got a family history of colon cancer in her maternal grandmother at the age of 83. She doesn't smoke, she's very healthy, her BMI is 23. No other comorbidities. And she wants to know about, she's worried about bowel cancer because of her grandmother. Okay, anybody have any suggestions what they do or wouldn't do here? Her main concern is bowel cancer, so we've got to address this concern. Would you offer a colonoscopy? You could. Would you offer a fit test? Could as well. Your index of suspicion here is quite low. Less than 2% of colon cancers in people over less than 40. Her grandmother confers a minimal risk. She's a second-degree relative. So with her, it would be reasonable to do routine bloods and a fit test. It would also be reasonable to do a colonoscopy. If you discuss the risks and benefits of each colonoscopy or fit test, they'd be the best way to do it. But your index of suspicion here is quite low, and that's the main reason just to talk about this case. Just want to talk about invasive tests. So they're the non-invasive tests. The invasive tests for colon cancer screening predominantly are CT, colonography, and colonoscopy. Okay, sigmoidoscopy I'll talk a bit about in a moment. With CT colonography, as you know, it's a virtual colonoscopy. No sedation involved. Bowel prep is required. I always tell patients, no matter what test that's required to look at your bowel, an invasive test, you have to clear the bowel out because we can't see through feces. Okay, so bowel prep is required. Barium enema is no longer used in colon cancer screening. Pictures are usually very good. The picture on the left there is a standard colonoscopy picture of pedunculated polyp, and on the right is what a similar image of that polyp on a CT colonography. Now, obviously, the problems with the CT colonography, exposure to radiation, detection of larger polyps and subtle polyps like serrated polyps is lower than with standard colonoscopy. And up to 10% of patients with colon polyps over a centimetre can be missed with the CT. It's only a picture. You can't biopsy, you can't remove. It's just a picture, okay? If you find something, up to 20% of cases will then need to go on to have a standard colonoscopy, which is very rarely you can do it on the same day. You're going to need to repeat the bowel prep, okay? So you've got to explain that to patients when you offer them this test. It is also a low dose, a non-contrast CT scan of the rest of your abdomen, so you can pick up stuff which you may or may not want to know about, but it'll also pick up liver lesions and any problems anywhere else in the abdomen. Just a little bit about sigmoidoscopy. It's still on the screening guidelines. but a lot of people say it's like x-raying one lung, screening for lung cancer. It looks at the left side of the colon, okay? It has been shown in a study in the Lancet 2010, reduces colon cancer incidence by 1/3 and mortality by 40%, okay? So it's very good at reducing that in the left side of the colon. Problem is 30% of all colon tumours arise in the right side of the colon, and it's not seen, okay? So for that reason, patients don't like it, doctors don't like it, everybody's uneasy from a screening point of view. So really it's not a popular screening modality, but it's still in the screening guidelines. And then we come on to the one we all know about, colonoscopy, okay? High sensitivity for colon cancer and all polyps. It can be a single session usually, and you can get long intervals. If you have a normal colonoscopy, you don't need another one for 5 or 10 years, depending on your risk profile. You can, as I said, complete examination of the whole colon, and some of the population-based screening studies, certainly in Germany and the US, have shown a huge incidence reduction of colon cancer and mortality, up to 80% in the distal colon, and 40 to 60% in the proximal colon. And the reason for the discrepancy is these serrated polyps, by and large. So obviously you have to talk about the complications, because when you're offering a couple of different options to the patient, you've got to talk to them about what the complications of the procedures are. So perforation is less than 1 in 1,000. You can see a small perforation on the left side there. Small perforations picked up quickly during colonoscopy can be managed endoscopically with clips now, not requiring surgery if they're small and picked up very, very quickly. Bleeding relates almost exclusively to taking polyps out. Standard routine colonoscopy without polypectomy, very rare to bleed. Death rate is very low, and I'll talk a little bit about incomplete exams as well. The miss rates, it's not a perfect test, nothing is. Between 2 and 6% of cancers can be missed on the first colonoscopy. So it's important to remember that if you're worried about a patient, particularly in the symptomatic group, if they come back with their normal colonoscopy results and they're still symptomatic, or you're worried about them, there is a miss rate, even in the best hands, in the best centres. Not everything is picked up. And the bigger the lesion, the less likely you are to miss it, but you can still miss big lesions, okay? Just another case in contrast to the previous case, a 56-year-old gentleman who's asymptomatic, okay? Now, he's got a family history and a first-degree relative, his father at the age of 52. He's a smoker, he's a type 2 diabetic, and he's overweight, okay? What would you offer him for bowel screening here? Yeah, I think everybody will agree. And the main reason being, he's got multiple risk factors for colon cancer. He's overweight, he's a smoker, he's a diabetic, and he's got a family history and a first-degree relative. So I refer him because there's going to be a high yield. There's a very high chance this guy's going to have a polyp if he doesn't have, he's not to have colon cancer, but he's going to have a polyp at least, okay? So that brings us on to the guidelines. They were updated just in 2017 by the Multi-Society Task Force in America, which represents the biggest gastroenterology and endoscopy societies over there. And these guidelines, in the first instance, for average risk people, no family history, no major increased risk for bowel cancer, they recommend you commence at the age of 50, okay? And what they've done is they've split up the options into tiers, okay? So in tier 1, you can offer your patient a colonoscopy every 10 years or a FIT test every year or every 2 years, okay? Now, there's about 5 different screening options, but if you offer them 2, they're much more likely to pick one of them, okay? Rather than offer them 5 and confusing people. So if the colonoscopy is normal, they wouldn't need another one done for 10 years, okay? Or you can offer them a FIT test every year. And obviously the risk profile will judge you, not force you, but will guide you as to which way you should go. The tier 2 test then, so if they don't want colonoscopy or they don't want a FIT test, you can offer them a CT colonography every 5 years if it's normal. The FIT fecal DNA every 3 years is not available here. And the sigmoidoscopy every 5 to 10 years, but I've explained the pitfalls associated with that. So if they don't want a standard colonoscopy or FIT test, CT colonography is probably the next best option. Tier 2, I haven't spoken about this much, capsule colonoscopy. This is a capsule that you swallow. You've heard all about it in the small bowel. It's not available routinely here yet. The big problem with capsule colonoscopy is you think the bowel prep for a normal colonoscopy is bad, you have to take double the prep for capsule, okay? So if you're going to get patients to do it, they're going to be brave patients. It misses a lot of polyps. It won't pick up the sessile serrated polyps. Again, you need a follow-up colonoscopy if it's clear, or if they see something. So you're going to need to go through the whole bowel prep again. They've already gone through a double prep. So it's not likely, it's going to be very like CT colonography. It'll be for people who are too frail or don't want a standard colonoscopy. It's not readily available here yet. So that's the screen. They're the guidelines for average risk. Now, what about the people with increased risk, family history? So if you've got, they recommend a colon cancer or an advanced adenoma, which as I said, is a bigger polyp, a villous polyp, or high-grade dysplastic polyp. If you've got either of those in one first-degree relative under 60 or in two first-degree relatives at any age, you should start screening at the age of 40 or 10 years below the youngest case, okay? And they recommend colonoscopy every 5 years for these patients, if they're willing to have it, okay? If you have colon cancer and advanced adenoma in a first-degree relative over 60 or in two second-degree relatives, again, they recommend to lower the age. Start at 40, but the interval screening after that is as for the average screening guidelines. So colonoscopy every 10 years if it's normal, or a biannual or annual FIT test. Any questions to date? Or we might want to ask questions at the end. The Irish experience then, so this is the bowel screen test. As you know, it's a FIT test that's been offered in the first round of offers to 60 to 69-year-olds through the post. Approximately 500,000 people were invited to take part, and about 200,000 were screened. Okay, so there's a 40% uptake. Okay, the aim is for 50%, but so for a first round, it's not bad. It's not ideal, it's not where we want to be, but it's not bad. Of those, 5% of them had positive FIT tests. Okay, so you can see the colonoscopy workload is dramatically reduced. We do not have the doctors or the money to do colonoscopies on these 200,000 people. So the FIT test, and that's the reason why a lot of the programmatic screening starts with FIT tests. Of those 5% of FIT positive, 82% attended for colonoscopy. It's quite low, but some of those were deemed not suitable for colonoscopy and had CT colonography. So 82% of them attended for a colonoscopy. 521 cancers, or 5.6% of all colonoscopies, found a cancer. The overall detection rate, 2.65 for every 1,000 FIT tests. 71% of these, thankfully, were at an early stage. Obviously, the prognosis is a lot better if you find her, as I'm sure, I think John will be talking about that later. Adenoma detection rate of 54%. So it's not supposed to be great for detecting polyps, but in fact, it actually is quite good. So if you've got a patient with a positive FIT test, there's a 50-50 chance they're going to have some sort of polyp in there. So you can advise them before they go for their colonoscopy that they're likely they are going to have a polyp. So another case that I came across just a couple of weeks ago, an 83-year-old lady came in asymptomatic, blood pressure on an ACE inhibitor, no other history, never had an operation, never had a prior colonic evaluation with colonoscopy or FIT test. What prompted her attendance was her sister in the US was diagnosed with colon cancer when she was 79. And her brother had surgery for what she thinks was a benign polyp, had a partial colon resection, but not too clear on what the histology was. What would you do? She's worried about bowel cancer. Anybody else? Would you tell her she's too old? Right. She's 83, yeah. You could, yeah. So obviously you have to discuss it with her. And obviously this is where the age and screening comes in. And the guidelines are the people who are up to date with screening and negative prior investigations, particularly colonoscopy, consider stopping when they're 75 or the life expectancy is less than 10 years. So if they've had 2 or 3 colonoscopies and they're 76, there's a good argument to say you don't need it anymore. Okay, you've had 2 normal colonoscopies, you're 76, the risks of colonoscopy go up as you get older. So it's very reasonable to have that discussion. But as you know, some 75-year-olds are like 45-year-olds and some are like 95-year-olds. So it's very much patient dependent. And people without prior screening, like Our Lady, consider screening up to the age of 85, depending on their age and their comorbidities. Okay, so she's 83, she's very well. She's come to see me about screening for colon cancer, so she's enthusiastic about a colonoscopy, and I've explained it to her and she's very happy to have it done. So I think it's very reasonable, and the guidelines would suggest you can consider screening up to the age of 85 if they've never had it screened before. Okay. So a little bit just about quality in colonoscopy. In these guidelines, the patients, and this is happening in America, the patients are recommended to ask their colonoscopist these questions. Okay. And it's going to come out and it's going to become public information. Cecal intubation rate and adenoma detection rate are 2 of the main markers for a colonoscopist as to their quality of their colonoscopies. And also they recommend to ask the doctor, do they split the dose of their bowel preparation? I'll talk about that in a moment. Cecal intubation rate, the aim is for us to get there to the end of the bowel 95% of the time. Okay, that's what we're aiming for, is to get there 95. Nobody will get there 100% of the time. The people who do are lying. Okay, you cannot get there in every case. Very important, we document it with pictures. All the reports, most hospitals now have electronic reporting systems, and we have to take pictures to prove we've been to the end of the bowel. The adenoma detection rate, again, we're aiming for over 20% overall. They say it should be 20% in females, 30% in males. If your adenoma detection rate is less than 20%, tenfold increase in an interval cancer rate. That's a cancer occurring before your next scheduled screening colonoscopy. So it's a very important marker of quality in colonoscopy. And some of the factors that will influence the adenoma detection rate, patient factors, obviously age is one. Males are more likely to have them, and the bowel prep is very important too. Colonoscopist factors, withdrawal time. That means when you reach the cecum, we document it. It's documented by the nurses at the time we got there. And then we're timed taking the colonoscope out, because obviously it makes sense. The slower you come out, the more carefully you look, the more likely you are to pick up polyps. If you're coming out less than 6, and the cutoff, 6 minutes is quite an arbitrary figure. I don't know where they came up. They just had to pick a figure when they were doing the study. But obviously, if you're coming out in 3 minutes, you're not going to see much, apart from something very large, and you're going to miss stuff. If you spend longer than 6 minutes, you're good. You should be spending more time looking at the mucosa, and you're more likely to pick up polyps. Fatigue is a factor. If you're going to get your colonoscopy, get it done early in the morning or early on an afternoon list. If you do it at 6 in the evening and somebody's done 20 colonoscopies, there is a chance you're going to be more likely to have a missed polyp. Ongoing CMA activity has been shown in studies for some reason as well, also to increase the polyp detection rate. The bowel prep now, which is most of the questions in the last room all related to, adequate preparation should be achieved in over 90% of cases. Okay, the single most important predictor of a successful prep is the interval between the end of ingestion and the start of the procedure. Okay, and this is the cornerstone of all screening programs and all colonoscopies. And this is why we now split the bowel prep. Okay, so you take half of it the night before, and you get up very early in the morning if you've got a morning procedure at 4 or 5 in the morning to take the other half. Okay, and we're not being mean, we're not being cruel. It's to improve the clear out. Okay, it improves bowel clear out. It improves our adenoma detection rate, and patients prefer it. Believe it or not, taking 4 litres or 2 litres of a drink the night before is pretty miserable. If you split it up, it's actually easier for them to take. Less interference with their, they're also suggesting now if you have an afternoon procedure, you take it all in the morning, okay, which is again with reduced work time, missed, less sleep disturbance. It is another possibility. And as you can see, the effect of split dosing on the left, on the right, you've got a perfectly clean bowel. On the left, it's quite dirty. And as you can see, if it's going to be dirty with this mucus layer and fecal layer on it, you're not going to pick up the polyps during that. Okay, so the bowel preparation is crucial. Okay, for all colonoscopies, not just screening. This is just a quick slide to say that people who have polyps, depending on the number or the size of the polyps, they also go into screening programs. Okay, so once we find a polyp, we have very specific guidelines depending on the size of the polyp, the histology of the polyp, and the number of the polyps as to how frequently they should have their follow-up colonoscopy. So that's why if they do have polyps, it'll often be 5 years if they've small number of polyps, 3 years if they've got a big adenoma, and if they have lots of adenomas, you're going to need it done more frequently every 1 to 2 years after the initial polyp is removed. Just in relation, the lifestyle factors, big Danish study a number of years ago looked at the risk of colon cancer in relation to points achieved in a lifestyle index ratio. Alcohol and smoking, we know about physical activity. The more you do, the less likely the chance. High BMI is also associated with, and these are things you've got to think of when you're seeing a patient, you're talking about the bowel screening. It's not just looking at the colon. You've got to take their comorbidities and lifestyle factors into it as well. With the diet, it's high fiber diet is good. Red meat, processed meat, not good. Okay. Metabolic syndrome, always remember, increases their risk by 50% of colon cancer and colon polyps. Okay. So definitely consider, lots of your patients have this colonoscopy. And then smoking, if a smoking study of this number of people, effects of smoking are comparable to having a first degree relative with colon cancer. Doesn't mean every smoker has to go straight for a colonoscopy. But again, when you're talking to patients, you've got to take this into consideration, okay, what their lifestyle and risk factors are for colon cancer. So just to summarize then, colon cancer screening is very effective. First tier tests are a biannual FIT test or a colonoscopy at the age of 50 when you're at average risk for developing colon cancer. If patients don't want that, a CT colonography is an alternative option. If you've got a family history and a first degree relative of either colon cancer or an advanced polyp, start at the age of 40 or 10 years below the index case. Serum tests, which will be the ideal test, are not available yet, readily available. Consider the lifestyle risks, as we spoke about, when you're actually deciding on how you're going to screen the patient. At the end of the day, the best test is the one that gets done. Okay. Any questions at all?
Thank you, Conor. We'll take questions from the floor.
As I said, these are actually American guidelines, so we don't have Irish guidelines per se. We usually follow them, but obviously this is where the sigmoidoscopy and the fecal DNA comes in. They have more tests available, but at the end of the day, most of them, they're not using the test that they recommend. They recommend sigmoidoscopy in it as part of the guidelines. That's why I spoke about it. But most people, if you're screening for colon cancer, it's unlikely either the patient or yourself are going to be happy with doing a half a bowel test. Do you know what I mean? Even though it does reduce colon cancer incidence and mortality, it's not ideal.
You mentioned the bowel preparation, which obviously is important. So if a person is going for colonoscopy on Monday, the split dose, do they start on Sunday and the next one on Monday morning, or do they start 2-3 days ago? Or how?
No. So what you do is, so the closer to the time of the test you take the prep, the more effective the prep. So people who don't have any adverse factors associated with a poor prep, like history of constipation, high BMI, or on antidepressants or tricyclics, you would take it. So I usually do with Movi prep, you get them to take one sachet of the Movi, 1 litre of it at 7 o'clock the night before. Take the other one at about 5 o'clock if they have a morning procedure, 5 o'clock in the morning. Okay? So the day before they can work normally. Their diet's reduced from lunchtime. They want to reduce their diet from lunchtime the day before, no solid food after that. Have their colonoscopy, and then if they're done in the morning, then have the colonoscopy. That's how we split the dose for a morning procedure. Okay, for an afternoon procedure, you can take the morning dose a bit later, 7 or 8 o'clock. So, yeah.
Sir, you also mentioned, I did not understand the screening, which you mentioned started at the age of 40 and 10 years. What is the 10 years?
If you had a brother with colon cancer at the age of 45, you start at 35. So it's whichever comes sooner, either age 40, or if 10 years below the index case is earlier than 40, you start at whatever that age is, 38 or 34. Jack?
Conor, that was a fantastic talk. I'm a gastroenterologist, people probably know me, and I must say it was a wonderful summary for the family doctors here. The question about 6 minutes withdrawal, it's a technical thing for the GPs, and they're not really that pushed about this, but for us it's very important. And it came from a study from Rockford, Illinois, a guy called Barkley, and they had 14 endoscopists. One guy came out in 2 minutes, and one guy used to take 44 minutes to come out. And he found, the guy 44 minutes, he found polyps in everybody, you know. Yeah. And the other guy never saw a polyp. And they had control of their 14 hospitals' data around them, so they knew the missed lesions were coming from the guys with quick withdrawal rates. You know. And then 2 surgical studies came out showing you could come out in 2 minutes if you're a surgeon, and you'd still be just as accurate. So, you know, but the data's old, but it is very, very relevant. The reason I wanted to ask you a question was about, we have a problem with patients who are over 90 kilos, and there's evidence that if you give them 6 litres, it works better than 4, and we do that regularly. I want to know, do you do that? And also the final question was, for patients over 75, I again, you know, say this to patients when they're over 75, look, it's controversial, you know, you may want to just hold off here, you know. And quite a few of them get quite annoyed about, say, you're writing them off and stuff.
Oh, definitely,
What kind of response do you get?
Well, certainly to your second question first, definitely. I mean, the first question is, it's the same with the screening for the Barrett's. When you sort of gently, somebody's been coming to you and they've had 4 or 5 colonoscopies with you, and you gently suggest that you don't need them anymore. They can be distraught. They're saying, am I too old? And essentially you're telling them, yeah, well, these are the guidelines. But I'd say you'll get a 78-year-old coming in who's very well and saying, I want another one. I mean, you can't say no, they're only guidelines. And if they're a fit 78-year-old, I have no problem doing one for them. But I'd always say that we'll always consider in 75-year-olds and over for either a symptomatic colonoscopy or a screening colonoscopy, I prefer to talk to the patient first, not do direct access. They need to know what the complications are. They need to know what the yield of the colonoscopy is. and the likely outcome of the colonoscopy and the risks before they go and do it, because some people will back off and say no. So I think it's very important just to have the chat with them. But at the age, and some people, you know yourself, will be very happy to say, yeah, I've had 4 done, they're all clear. And you say, listen, your chances of getting colon cancer now are very low. And they're usually quite happy with it. But the age thing, you've got to be very careful with. And the first question, the prep, I was asked the question, the other one was, what's your second line? Obviously, if you're going to be over 90 kilos, I'd be more likely to go with clean prep rather than Movi prep. But again, then you do the clean prep and the poor prep, what do you do next? I will often give them a laxative like Movicol for about a week or 10 days before the bowel prep. Some people, like you said, will give them 6 litres of clean prep. There's no right, I think everybody has a different, there's no guidelines as to what you should do next, or should you reduce the fibre in their diet for a week beforehand. I mean, years ago we used to do dietary preparations for a week or 10 days before the colonoscopy. That's not necessary in most people. So it is a very difficult problem, is that poor bowel prep is very difficult. And as you know, once you've had one poor bowel prep, the next one's likely to be poor no matter what you do anyway. But what's the best thing to do? It's hard to know. Increase the bowel prep, start a laxative. I generally tend to go with Movicol for a week beforehand, and then give them clean prep.
Thank you, Conor. Any other questions? Okay, thank you, Conor. We'll leave it at that. Thank you very much. Appreciate it. Thank you. So our third speaker, is he due to come? No. Yeah. No worries. Okay, we'll take a minute then. Yeah, perfect, okay. Will we take a minute if anyone wants to stretch their legs or whatever for a few seconds? Welcome to pop out.
Wish we glittered in the sun. Summer came for the last time. Circle tracks down one by one. So we slow motion at once. Fraction of my shadow's light.
Now, so we'll start back. Our final speaker this morning is John Burke, who's a colorectal surgeon, and he's going to talk to us about common anorectal complaints. Thank you, John.
Thanks very much. I'm sure it's been a long morning for you, and the last thing you want to hear is another 30 minutes talk about proctology, but we'll try and lighten it up a little bit and go through some clinical scenarios, and I'll show you some videos of some cases. In terms of my background history, I'm a graduate of UCD. After that, I did a period of research in inflammatory bowel disease, which is one of my main clinical interests. And after higher surgical training in Ireland, went to Cleveland Clinic and then Florida Hospital in Orlando, where my focus was on IBD and minimally invasive surgery. I was appointed to Beaumont in 2015 and started in Blackrock in the summer of 2016. So a lot of the sort of heavy lifting work I do revolves around colorectal cancer and IBD. And what I'm going to talk to you today is some of the kind of common anorectal problems that we see, the hemorrhoids, the fissures, the fistulas, and these are obviously remote to the general surgery problems that I treat. So what I'm going to talk to you about today is some of the common clinical presentations, so anal pain, which may be due to a fissure or an abscess, bleeding, which can be due to hemorrhoids or a fissure, or the worrisome thing that none of us want to miss, which is rectal cancer, fecal soiling, perianal itch, and problems with obstructed defecation. So the first case is a 26-year-old man who comes in complaining of anal pain on bowel movement, which has been going on for 6 months with associated intermittent PR bleeding, and says to you, "Doctor, it's like passing broken glass." And this statement for me is almost pathognomonic of an anal fissure. It's remarkable how many patients will actually say these words to you. And examining these patients can be quite challenging. When somebody gives this history to me, I wouldn't even attempt to do a DRE because it's so exquisitely painful for them. So what I try to do is to avert the buttocks, and by doing that, you'll evert the anal canal, and you may see a sentinel tag at the 6 o'clock position or the beginnings of a fissure. And this clinical scenario for me is sufficient to commence empiric treatment for an anal fissure. So it's a common problem that I see, and why does it happen? Well, all it is a cut in the anoderm, the skin which lines the anal canal. And unlike a cut that you get in your hand or your face, it doesn't heal because every time the patient evacuates, it re-tears, and their internal sphincter becomes hypertonic. So that the internal sphincter, just here, squeezes very tightly, and that cuts off the blood supply to the anoderm, so it won't heal. So all the treatments that we employ are about relaxing that muscle and increasing the blood supply. So my management algorithm when I see these patients for the first time is I will prescribe them AnoHeal, which is 2% diltiazem, Instilogel, and Movicol, and I'm quite prescriptive about how these things are used. So I give them Movicol because passing a bowel movement is very, very painful, so they do it less often when they have a fissure. Then, as a result, the bowel movements are harder, and it makes the whole process more intolerable to them. I advise them to take the Instilogel 30 minutes before going to the bathroom. So apply the Instilogel topically around their back passage 30 minutes before they go, which again makes the process less painful. And as the treatment mechanism, I prefer AnoHeal versus rectogesic or GTN paste. In my practice, I find a lot of the patients that I prescribe GTN to, even though it's cheaper, don't take it because it causes headaches. And as a result, it's less efficacious. Both of them work via a similar mechanism, and they're both equally effective. But if the patient isn't taking the treatment, it's not going to work. So when prescribing the AnoHeal, I tell them to sign up to the drug payments system so that they can get 2 tubes, which will complete the 6-week course, and it will limit the amount they have to pay during that month. I'll then see them back at 6 weeks, and if they've no improvement, I'll give them I'll perform an EUA and inject Botox. And if that still hasn't worked, then I'd consider them for a lateral internal sphincterotomy. This is a procedure that sort of went out of vogue in surgical practice because due to its injudicious use, patients were becoming incontinent. but it is the most successful treatment to treat a recalcitrant anal fissure. And if it's done correctly on the right patient, they're extremely grateful. Just this week I saw a lady back who'd had Botox injection with another surgeon, and it hadn't worked. And when I examined her, you could see why. She had a really, really thickened and scarred hypertonic internal sphincter. There was no way 20 cycles of Botox were going to ever work for her. So after counseling her about the risk of continence impairment, we went on and did this. And she said the next day, the spasm, the pain, which was really affecting her quality of life, had gone. So it's a very successful treatment when done correctly. What's the evidence behind these treatments? Well, when you compare head-to-head Botox with AnoHeal, you get equivalent healing at 3 months, but Botox works more quickly. So if a patient is quite troubled the first time I meet them and they want to move on with an EUA and Botox, first of all, I'm happy to oblige in that regard. You don't disadvantage the patient by doing so. When you summate all the evidence, sphincterotomy is associated with a continence disturbance rate of 14%. That's what's quoted in the literature. That hasn't been my experience. In fact, a single patient that I've done this procedure on has not come back and said that they've had impaired continence to gas or to stool. Now, I'm very careful about who I do it on, and I think if you adopt that, then you won't have this problem. I was at a lecture by a professor of surgery from the UK who was speaking in the US, and in a typically UK manner said, I'd like the ladies in the audience to raise their hand if their husband is continent to flatus. So it's important to explain these things to patients, but explain them in a way that doesn't terrify them about the procedure. The second case is a 35-year-old gentleman who comes in with intermittent pain in his back passage and a periodic swelling next to his anal canal, and has some pus staining of the underwear, and he's tried some antibiotics. And when I examine the patient, I see this external opening here at the 2 o'clock position, and when one does a DRE, you can often feel the internal opening. And when you rub between the two, you can very often feel the fistula tract that's there. So the most common reason for a fistula is a cryptoglandular abscess. So at the dentate line between the anus and the rectum, there are these glands which produce mucus. And if they become blocked, an abscess can form, and the easiest place for that to drain is through the muscle. And this leads to a fistula in ano. And unfortunately, this will not heal by itself. It will recurrently drain, periodically block, and result in an abscess. In terms of management, if you see a patient with perianal induration with no fluctuance, then that is somebody who can be appropriately treated with a course of oral antibiotics like Augmentin. However, if there's a fluctuant swelling there, a clear abscess, this is unfortunately a patient who's going to need to make a trip to the emergency department to have their abscess drained. Usually when I see these patients, it's at a point after this where there's an established fistula in ano. And the first thing I'll do is to place aceton to drain any infection and allow the tract to scar down, which will bring them on to the second stage of the procedure to definitively close it. And these are the surgical options at our disposal. One of the procedures that I particularly like is the lift or the ligation of the intersphincteric fistula tract. So this is a newly described procedure where we make an incision between the internal and external sphincter and actually ligate the fistula. It's very successful, it's very well tolerated, and because you're not actually cutting muscle, it doesn't affect continence, which is very important, particularly in female patients. So very often patients will ask, am I, just because I've had an abscess, am I going to get a fistula? And the risk of that is thankfully low. This is epidemiological data from the UK, and only 16% of patients who've had an abscess will go on to get a fistula. But if they have Crohn's disease, then they've got a 50-50 chance of getting a fistula there. Why might I choose one of these procedures over another? Well, if a patient has less than 25% of their sphincter muscle involved, then I'll do a fistulotomy because it's the most successful procedure in terms of fixing the fistula. Just lay the whole thing open. But if there's more muscle involved, or if it's in a female, then I'll choose one of these others. And when I am consenting a patient for their second stage procedure, I'll consent them for the full menu. And I'll say, I'm going to decide which one is the most appropriate when you're being examined under anesthesia. The third case is a 33-year-old gentleman who describes bright red PR bleeding for the last 3 years, what I describe as outlet bleeding. So it's on the paper, it squirts into the toilet bowl, it's not mixed with the stool, and it's not associated with other red flag symptoms, change in bowel habit, urgency. He's got some prolapse of tissue on defecation and some perianal itching, and he's tried Anusol with no improvement. And when I examine him, he's got some grade 2 hemorrhoids. So hemorrhoids are phenomenally common. 50% of the population have them with varying degrees of symptoms at different times. The symptoms are as we described, and in the first instance, these patients should be advised about their fibre and fluid intake. So in the office, I have a high fibre diet sheet. I give it to the patient and advise them to drink at least 2 litre water per day. And also, I give them some advice about the amount of time they spend on the commode. So when you ask patients, it's remarkably surprising how many will read a book, a magazine, or their iPad on the toilet. And the act of actually sitting in that position causes the hemorrhoid columns to hang down and worsens their symptoms. So in the first instance, this is what I'll advise patients. Usually, then, they've already tried these, and I'll move on to the next step, which is the operative treatments. So the minimally invasive treatments that you'll often see coming back on a letter or a scope report is the injection of phenol or hemorrhoid banding. So why would I do one versus the other? Well, if they're grade 1, I'll inject oily phenol, and if they're grade 2 or 3, I'll do rubber band ligation. Both tend to be very well tolerated and associated with minimal complications. They have about an 80% success rate, so patients need to know that these problems may come back. But the operative approaches to treat hemorrhoids are painful. These are quality of life problems, and you don't want to make somebody worse by just treating their hemorrhoids. So the traditional thing is the hemorrhoidectomy, where one excises the hemorrhoid column. You can see the internal sphincter there, and it's stitched closed. And this is a phenomenally painful procedure. In my practice, a patient really has to earn this operation. They'll have to have tried all the conservative measures, banding a couple of times before having this operation. And I'm very clear with them that after this, you're probably going to be out of work for 2 weeks and going to require a lot of pain relief to get you through this. They won't thank you in the first week or two. 6 weeks down the line, when you see them back, they're happy. But in the initial stages, they aren't. One of the procedures I quite like is the stapled hemorrhoidectomy, which is where we remove a cuff of hemorrhoid tissue within the rectum, and that pulls the hemorrhoid columns back up. This is very well tolerated as a procedure because within the rectum itself there are no pain nerve endings. So while patients may experience a little bit of bleeding or some fecal urgency after this operation, they tend not to report the acute anorectal pain after a hemorrhoidectomy. So in terms of my management algorithm, when I see these patients for the first time, I'll characterize where the hemorrhoids are and their grade. So they're normally at 3 places, 3, 7, and 11 o'clock. I'll do a colonoscopy in the first instance if they haven't had one already. So if they're under the age of 40, I'll do a left-sided scope, provided they don't have any other red flag symptoms. If they're over the age of 40, they'll get a colonoscopy, and I'll treat them with either injection or banding. I'll give them dietary advice, often prescribe fibre gel, and I'll tell them to call the office in 8 weeks if they haven't had any improvement. If they're smaller type hemorrhoids and they still have symptoms, I'll consider rebanding them. If they have one dominant column that's hanging down, I'll excise that with a Ferguson hemorrhoidectomy because that's the best treatment for that patient. But if they have multiple columns, I'll use a stapled hemorrhoidectomy. And what's the evidence for this? Well, this trial from the UK demonstrates that stapled hemorrhoidectomy is less pain, but if you excise the hemorrhoid, you've better prolapse control. So that's why I do that if they have just one main column. Something you may see in letters coming back now is hemorrhoid artery ligation, which is a procedure I don't perform. This is why. This is a trial from the UK published in the Lancet last year, where they compared banding with hemorrhoid arterial ligation, which is essentially stitching the hemorrhoid back up. And what they found was that hemorrhoid arterial ligation was associated with significantly more pain. There was a slight increase in success rate at a year, but what they found is that if they just brought the patient back and banded them a second time, which is essentially a painless procedure, that the efficacy was the same. So in my opinion, banding a patient twice is better for them than doing the hemorrhoid artery ligation once and causing them a lot of pain. The next case is the thing none of us want to miss, which is the rectal cancer. Patient comes in, they have PR bleeding, loose bowel movements, and urgency. And when one does a rectal exam, you feel a palpable mass. Unfortunately, rectal cancer is something that's increasing in incidence, particularly in young patients. And the patients themselves don't present to any doctor because they believe their symptoms are secondary to hemorrhoids. One of the procedures that I perform is TAMIS, or transanal minimally invasive surgery, for large polyps or early stage rectal cancers. And previously, these are patients that often had a low anterior resection or another sort of gruesome proctology procedure. This is just a short video of one of these procedures. So this was a gentleman in his early 70s that was referred to me by one of my gastroenterology colleagues. So when our gastroenterologists are removing polyps, they often lift the polyp with a solution, some saline. And if the polyp lifts nicely off the mucosa, that we're reassured that it's not invasive, it's not a cancer. So they'd started the dissection, and then they found the center of the polyp wouldn't lift, and felt this could be a cancer, and sent them on to me for this procedure. So this is an anterior lesion within the rectum, and I'm starting my dissection here. So we're just using a simple electrocautery here. So we've marked out the lesion circumferentially, and we're removing a full thickness segment of the rectum. So this is anterior in a man, so the prostate is just anterior to where we are. So we're carefully cutting out the segment of the rectal wall in a full thickness manner, which lets our pathologist get a really clear picture of what's going on. And this actually turned out to be a T1 cancer with very benign features. Previously, this is a patient that would have had a low anterior resection with all the associated complications and long-term poor functional outcome. But now we know that it's safe to manage these patients in an observational manner. So we have a protocol for surveilling these patients where every 6 months they get an MRI scan and a CT, and if there's any evidence that there are local lymph nodes enlarging during that time, then we can go back and do the traditional operation. And then we stitch close the rectum here after the procedure. However, we still need to do the traditional operation for rectal cancer, which is to remove the rectum. Rectal cancer is managed in a slightly different way to that of colon cancer. If somebody has colon cancer, you remove the segment of the colon, and then if they have positive lymph nodes, they receive chemotherapy afterwards. Rectal cancer is slightly different because the rectum sits within the bony pelvis, so you're at risk of getting a positive margin, which is the most important thing in terms of their long-term outcome. So 60% of our patients today will get radiotherapy before surgery to shrink the tumour in an effort to get a clear margin. And where I work now, our positive margin rate is 2.5% because of this sort of management strategy. This next video is just a patient who had radiotherapy for locally advanced rectal cancer and is operated on using the same operative platform that I described there. So to do this operation, we have to mobilize the left colon so it comes down to the rectum to be able to join things back up. Here we're dissecting out the blood vessels associated with the mesentery of the bowel so that we get all the lymph nodes to make sure that we don't have any positive lymph nodes left behind. Then we go down into the pelvis and we're dissecting the rectum out from within the pelvis. Now this is was traditionally a very hard thing to do laparoscopically because you're operating it within a very confined space. But now using this technique, we're able to operate through the back passage and remove the rectum from below. So we've stitched closed the rectum beneath the tumour, and now I'm cutting through the rectum and removing it and all the associated lymphatic tissue very, very carefully. Then we've joined up to our dissection plane from above. And then and in certain instances, you can remove the whole specimen through the back passage itself. And then we put the bowel back together again. And because there are essentially no scars after this operation, these patients have fantastic pain control following surgery. So back to some more benign pathology. The next case is a 63-year-old lady who describes periodic fecal incontinence. She's had 3 children, the heaviest 9 pounds, and in our first delivery, the use of forceps was employed, and she had a tear. And on examination, she's got a lax anal sphincter. So it can often be challenging to assess a patient's ability to contract their sphincter in the office. And often what's helpful is if you say, oh, can you try and pull my finger in, or pull your bottom up to your tummy, gives you a more accurate appreciation of their squeeze pressure. In the first instance, I'll take a full medical and medication history. So are there any medical conditions that may be affecting stool consistency, or any medications that may be causing loose stool? I'll do a Wexner score and document that very carefully. This is a scoring system that's available online, and it enables you to characterize the severity of a patient's incontinence. It's scored from 0 to 20, 0 being perfect, 20 being very bad. And I'll try and gauge the impact their incontinence has on their quality of life. I'll examine their anal rectum and their perineum to see if there's any scarring from prior surgery. And in the first instance, the management is conservative. So I'll advise them regarding a low-fiber diet, and I'll give them a dietary advice sheet regarding low-fiber foods. I'll prescribe them Imodium and refer them for pelvic floor physiotherapy. And Blackrock now has an excellent pelvic floor physiotherapist called Aoife Clark, who's very, very good at going through pelvic floor strengthening exercises. In 80% of patients, these simple measures will resolve their symptoms, 80% without any further intervention. It's important for these patients to realize why they're incontinent, and it's due to reduced cortical awareness of the rectum being full. So for the majority of patients who have incontinence, they're female, and it's secondary to childbirth. And the reason why they're incontinent is not just that their anal sphincter is weak, but they have a reduced ability to appreciate that their rectum is full and they need to evacuate. So the rectum fills, and as a result, they leak. So all the treatments that we adopt are to try and increase their awareness of that. So if you make them more constipated, they're more aware of a constipated stool in their rectum than a loose stool. And the majority of these patients, when you ask them, oh, do you take a high-fiber diet? Oh, all fiber, doctor. Great, brown bread, all that stuff. And that, despite what they think, is actually making them worse. Regarding the Imodium, you try and identify when the patient is troubled by their incontinence. So is it when they go out to the shops? Is it when they go for a drive? Is it when they go to play bridge? And taking 2 Imodium tablets an hour before one of these events is really going to improve their quality of life. And then I'll see them back and see how they're doing and repeat the Wexner score and see if these simple interventions have improved things for them. After that, if they want to be considered for operative intervention, if they haven't had a good result, we would do manometry to get a formal read on how severe their incontinence is, and do endoanal ultrasound. And really the treatment du jour is the sacral nerve stimulation. It doesn't increase the squeeze pressures of the anal sphincter muscle, but it increases cortical awareness. So patients are less likely to be caught short, and that's why it's successful. Sphincteroplasty, which is a suture repair of the sphincter, is done very rarely in 2018, because we know that whilst it has a short benefit in terms of a year or two, it's not durable, and you're exposing a patient to a relatively big operation with minimal long-term benefit. The next case is the 44-year-old gentleman who comes in and says his bottom is inchy. It's driving him crazy. This is something I frequently see, and on exam, very often the patient is overweight and is sort of moist perianally. So the important thing here is just to outrule a treatable or remediable cause for their pruritus. The most common cause I see is hemorrhoids, and then one has to outrule the other things that we've talked about here today: perianal fistula, fissure, tags, fecal soiling, which can be corrected as we just described, rectal prolapse, warts, or the more worrisome perianal cancer can present in this, the typical dermatological conditions, or venereal disease. Again, the history is very important here. One thing that I've picked up over the years is that excess wiping with baby wipes is very common in this patient population and worsens their symptoms. What happens is the anal glands around the back passage produce a natural oil, and when they excessively wipe these oils away with a baby wipe, these glands overactivate. So they're overproducing these oils, and that in turn is worsening their itch. So if they're excessively hygienic with wipes, etc., that's going to worsen their symptoms. So they should be advised to keep the area dry, and if they are incontinent, to control seepage as we described. General advice: weight loss and hygiene. If you feel there's any stigmata of a fungal infection, this should be eradicated, and something as simple as Canesten 3 times a day for 2 weeks can be very helpful. And then eliminate any dietary or other triggers. So one of the most common dietary causes of perianal itch is too much coffee. So if the patient is drinking 6 to 10 cups of coffee a day, you should advise them to reduce that down. The general things you'd ask somebody about any itch: have you changed a soap or a shower gel recently? For me, when I meet these patients, if they haven't had a recent colonoscopy, I'll perform one to make sure there's no secondary cause, such as IBD, which might be causing overproduction of mucus, and I'll treat their hemorrhoids. If that hasn't worked, then I'll treat any fungal infection, and again, if that hasn't worked, perform an EUA, because whilst a colonoscopy is a fantastic tool for examining the colon and rectum, it's not designed to examine the anal canal, and very often this requires an EUA. And at that time, we can send off skin shavings to see if there's anything unusual or a fungal infection there. And if I've gone down this paradigm and they're still troubled, a 6-week course of betnavate and an emollient cream like E45 usually solves their problem. If none of these things have worked, then I'll send them on to a dermatologist for a second opinion. Sometimes you can see unusual things, psoriasis, like that, which can cause these problems. The last case then I'm going to describe is a patient with symptoms of obstructed defecation. So 63-year-old lady, 3 children, heavy deliveries, and has had a prior hysterectomy. She's got difficulty evacuating and describes incomplete evacuation, so that when she goes to the bathroom, she always feels that there's something left behind. She's had to digitate her vagina to evacuate on more than one occasion, and has had 2 episodes of full-thickness rectal prolapse. And on examination, she's got a lax sphincter with some mucosal prolapse from the rectum and a rectocele. So obstructed defecation is a relatively common problem in older female patients. And the differential diagnosis would be things like anismus, where you've got excessive contraction of the pelvic floor. So for somebody to evacuate their rectum, their pelvic floor must relax to enable the rectum to empty. Intrarectal intussusception is where when one is trying to evacuate, the rectum telescopes through itself, like pulling a sock through along itself. A rectocele is where the rectum pushes into the vagina, and rectal prolapse is where the rectum is prolapsed externally. Any of these things can result in symptoms of obstructed defecation, and like all of what we do, it's important to exhaust all conservative measures before even considering a surgical approach. So for these patients, dietary advice to increase their dietary fiber is very important. One can consider laxatives. In certain instances, a suppository may be very helpful if you've tried these other things. It doesn't have to be a microlax enema. It could be something as simple as a glycerin suppository, which will help them feel that their rectum has been completely evacuated and improve their symptoms. And again, pelvic floor physiotherapy is critical in patients with all of these problems. And for the majority of patients, again, these conservative measures are sufficient without requiring operative intervention. For me, if they've gone through all this and they're still symptomatic, the defecating proctogram is a very helpful tool in discerning what exactly is the problem and who may benefit from an operation. What we do is contrast is inserted into the rectum, and they evacuate under fluoroscopy. So you can see, is the rectum pushing into the vagina? Is the rectum telescoping on itself? Or is there full thickness rectal prolapse, as you can see here? And that in turn will determine if the patient would benefit from surgery. And this is just one final video of a robotic ventral mesh rectopexy. So as we know, we now have the robot in Blackrock, and it is particularly helpful for procedures deep down in the pelvis where some suturing is required. So this was a case that I did from the US where a patient had internal rectal intussusception and as a result had symptomatic obstructed defecation. So the mesh is placed between the rectum and the vagina, which stops the rectum telescoping through itself and therefore enables the patient to have unobstructed defecation. But all of these cases in 2018 have to be discussed at an MDT, given the problems with mesh that we have. And today we've moved away from using non-absorbable mesh to absorbable mesh for this operation. So that's the end of what I have to talk about. These are common problems I see frequently. I'm sure you do too. Very often have a significant effect on quality of life for these patients. And there's much that can be done for them to improve that. Thanks very much.
Thank you, John. We'll take questions from the floor if anyone has any. No one volunteering? Okay. Yes, thanks, Jack.
Hi, I'm Jack Hollingsworth, gastroenterologist. There's a fantastic summary of all these problems in this area, and by far the commonest thing we see is perianal itching, is people putting soaps on, and we tell them just to use E45 to clean themselves in that area. But I was interested about the fibre thing, because when I was a kid we were told they needed fibrogel and more fibre for incontinence, and you were saying in your slides there less fibre is better now.
Yeah.
Is there good evidence for that? Like, is that your practice, or how did that come about?
So it came about because we sort of recognized that the primary problem for these patients with incontinence is that they're not aware that the rectum is full. And if a patient has a more formed stool, they're more likely to be aware that the rectum is full and they're less likely to leak. So the patient with liquid stool they've more difficulty controlling that stool. They're more likely to leak.
Do you recommend fibrogel for these patients? No?
So fibrogel is an interesting one. It's not really a laxative per se, but it's isophaga husk. So it's very good as a stool softener, but it's also a stool bulking agent. So in certain instances, I may use fibrogel in somebody with incontinence to bulk up their stool and to make them more aware of it. But the first things that I will use will be advice regarding a low fibre diet and Imodium. And if they're still having trouble, I will consider using fibrogel, but for its role as a bulking agent, you know.
John, can I ask you just in relation to, sometimes you come across some of these patients who have sort of tried every single cream, and then when they go off to someone like yourself or maybe a dermatologist, they're often kind of told maybe stop everything actually, because sometimes the over-treatment of the situation makes things worse. Do you have any comment on that?
No, I find that's absolutely true. You know, I think the important thing is if you can is to treat the underlying cause. You know, if you can identify a cause for this problem, that's the patient that's probably going to have the most durable success. But for a lot of patients, a cause isn't found, and we're sort of going through these different treatment modalities. And you know, the more time I think the patient spends thinking about it, you know, the more of a problem it becomes. You know, there are kind of end of the line treatments that we can do, such as injecting methylene blue around the back passage. Now that gives a permanent tattooing effect, but it numbs the nerves so that they don't experience itch. I've only ever had to do that once for a patient with intractable pruritus. But for Unfortunately, when patients come to see, a dermatologist, or, they feel, okay, let's start from the beginning, and they'll sort of slowly reintroduce one thing at a time, But yeah, I'd certainly agree that that's something you see.
Yeah, okay. Anyone else? One more there.
My question perhaps come under your specialty is the pilonidal sinus surgery. The patients are very troubled, and most of the time they are recurrent. Is there any advance in the pilonidal sinus surgery? Are we still taking that patients are treated with antibiotic, end up in surgery, and then the same thing happening again and again? Would you have any comments on it?
Yeah, it's so I look after a lot of patients with pilonidal sinuses, and it's a real disappointment to me, as a condition and as the treatments we offer, So in terms of surgical treatment, we excise the affected area, and we can either leave it open or close it primarily with a flap, And all patients I'm very clear with, the evidence would say that 50% of the wounds will break down, and 50% down the line they will recur. Now, in terms of surgical intervention, once they've healed up, the patient should be very clearly advised regarding hair care. So what happens is that the hairs from the lower back get trapped in the crevice between the buttocks. And if they keep that area hair-free, they're less likely to get a recurrence down the line. So it doesn't have to be waxing or electrolysis or anything like that. But even if they get clippers that they would use on their beard and run it over their lower back and buttocks every 2 weeks, that's going to reduce their risk of recurrence significantly. The problem isn't with pilonidal sinus. The word pilonidal comes from the Greek, so pilo meaning hair and nidus meaning nest. It's not ingrown hair, but hair is falling down and getting trapped between the area. And we know that because very infrequently you will see that hairdressers get pilonidal sinuses between their fingers. So it's not the hair is ingrowing, but the hair is getting trapped. So if they keep the area hair-free, then they're more likely to get a durable result. But it's not a happy condition. So.
Okay, we've one more at the back.
I had seen a patient 6 months ago with perianal itch, so I gave her Dactocoat. She had a bit of inflammation around the area. She came back after 3.5 weeks. She loved it. She required another one. I gave it to her. I'm just thinking, should I have referred her to be checked for a colonoscopy or?
Not necessarily. If the Dactocoat is working, then this is probably a primarily dermatological condition. The reason why I do a colonoscopy is just to outrule an occult cause, something primarily within her colon that might be causing the overproduction of mucus, because I don't want to miss anything. But if she's having a durable result from that treatment, it's probably a primarily dermatological problem. So.
Okay, any others? One more at the front there.
Hi there. Mine's just a quick question. Should we be waiting for women to finish their families before referring them for treatment, surgical treatment of hemorrhoids?
It's a good question. No, is the answer. So the majority of women will experience some hemorrhoidal symptoms during pregnancy. Very often they self-select, and say, no, I won't, because what happens is during pregnancy, due to reduced venous return, the hemorrhoids get bigger, and very often they'll get a thrombosis, and these are all difficult things to manage. Then, after delivery, they're busy with, with things at home, and very often they'll self-select. They won't come, for medical attention. Between deliveries, I'll certainly see patients and treat them. And even something as simple as hemorrhoid injection will improve their symptoms on subsequent deliveries. But I'm very clear with them that even though we do something, that their symptoms may worsen during the next delivery, Both injection and hemorrhoid banding are only 80% effective. So many of these patients will have had treatment 5 years or 10 years ago and come back for further treatment. But that's okay. These are common problems. So.
Okay, well, I think we'll leave it at that. Thank you very much, John. Appreciate your time
Thanks very
and effort
much.
this morning. So that concludes our session for this morning. There is coffee still available if you want to pop in and get a cup before you go. Thank you, everyone. Thank you to Blackrock Clinic and to the hotel as well for hosting us. Thank you.